Hi, I'm Dr. Jack Shilling. I'm the Director of the Joint Replacement Program here at Cooper University Hospital and the Cooper Bone and Joint Institute.
My name is Nicole Martino. I'm a physician assistant here in the Joint Replacement Department.
So what we're going to talk about today is we're going to have a general conversation about arthritis. We'll probably field some questions along the way. We're going to talk about non-surgical and surgical treatments of arthritis and the expectations around the entire process. So we hope that you find this informative and enjoyable. We've had some questions come in already, and a lot of them relate specifically to surgery. One of the things that I would say first is that if we're talking about hip and knee replacement, we should just basically have an understanding about arthritis. And arthritis is a cartilage problem. It is not to be confused with osteoporosis, which is a bone problem, but it is basically the tread on the tire in joints wear down, whether it's the hip, whether it's the knee, whether it's the shoulder. Those are the three most commonly replaced joints. And there are a variety of treatments that you could come to see myself or Nicole for to try to help with these things. And so the first thing that's important is diagnosis. And so when people come to see us in the office, we do a whole bunch of different things. We do physical exam, we do x-ray. What kind of things have you seen patients complain about when they're having arthritis in their hip or arthritis in their knee?
So typically by the time they come and see me, so they already have the diagnosis. So most of the time patients are experiencing pain in their knee or hip, have seen their primary care physician, maybe even had an x-ray, come in to see us and say, oh, I have arthritis, I'm having trouble functioning, work, taking care of my kids, doing laundry, things like that, and I need some treatment.
Yeah, Tylenol, anti-inflammatory medications, really common things that people will take in the beginning. Most people are limping. I mean, knee pain is usually knee pain. Hip pain is typically groin pain, and it's people may have pain in their low back, they may have pain in their buttocks, but and it doesn't mean all groin pain is hip joint pain. But if you do have arthritis in your hip, that's where it can come from. People sometimes think they have a hernia. Sometimes they think they have a groin pull that just won't go away. So there's different things to complain about. A lot of people will say, you know, I can't get my shoes and socks on because I can't bend my knee, I can't bend my hip, I can't get in and out of a car. So these are all common things that people are discussing and having trouble with. And oftentimes by the time people get to us, as Nicole said, they've tried some simple things. You know, they've done the Advils and the Aleve. They've done some Tylenol. Some physical therapy, some exercises, trying to get their conditioning levels up, trying to get their weight down. And they may have an x-ray that suggests, again, that they're losing some cartilage and that the bones are starting to rub and they're having trouble. So once that happens and they get to see us, there's a couple of things that we're going to try. There's two kinds of injections. People ask us a lot of time, you know, if we're not going to do surgery and we've already done simple things, what kinds of things can we do? And there's basically two families of injections. Tell them a little bit about those two kinds of injections.
So first being cortisone injection, steroid injection, which you'll typically hear, which is an anti-inflammatory we inject into the knee to help take away the inflammation that arthritis is causing your knee pain. So we can give that to help calm down your symptoms, which is really what's bringing you into the office to see us.
Yeah, I like to use steroids a lot because in a situation where somebody comes in and they're in a lot of pain, because you can put a fire out that way. And what I tell most people, and Nikki would say the same, is I know this is going to help you. The question is, how much does it help and how long does it last? And that's really what's different here. The treatments from person to person to person are often the same things. It's just that the response isn't really the same thing.
Based on activity level and
based on
a
variety of different things.
Yeah.
And I think that you know, it's important to understand that for 99.9% of the people that we're talking to, one of the things I say is, look, it's arthritis. It's a nuisance problem. It's not cancer. It's not a stroke. It's not a brain tumor. It's not a dangerous thing. It's just annoying, and it's a lifestyle-threatening problem. So we're trying to get things going in the right direction. And steroids are oftentimes the thing that can really help improve symptoms quickly and get somebody to a better place.
Now, that doesn't give you significant relief or a long enough time. So I'm saying 4, 5, 6 months, even longer. Then we are escalating to visco supplementation, which is a lubricating gel. Chicken fat, some of my patients will say when they come in to see me, can I get the chicken fat injection? And that's a series of 1 to 3 injections into the knee, given similar to cortisone injections that helps lubricate. I say so you're not rubbing bone on bone to give you some relief in between.
Right, and again, people will sometimes say, which one's better? And the answer is, it's not that one's better or worse, they're just different. One is an actual medication working on the inflammation itself. One is a lubricant trying to prevent the inflammation. And they both can be effective, but they both may not be effective. And so I think, again, it's important to understand that the treatment of these things is a continuum. And when you're talking about surgery, that's at the end of the line. And someone who is going to start having a conversation about surgery is going to they will have been in a place, if we're doing it properly, where they've done the pills, they've done the therapy, and then by the time that they get all the way over here, and they're starting to ask questions about, am I a candidate for surgery? The answer really comes down to, well, yes, you have a bad x-ray, but beyond that, you've tried all of these things. They aren't really working as well as you would like, and you're pretty miserable and frustrated with your quality of life, and so you decide to do something else. And at that point, that person's making that decision. I mean, we rarely
jump right in.
Tell somebody, hey, you need surgery.
Yeah.
In the end, the knee or the hip will tell the patient, and the patient will tell us when it's time, because really they've got the problem, but they've also tried a bunch of things that just haven't helped, and they're pretty unhappy with their quality of life. So, I think that's a fairly basic overview of arthritis and some of our philosophies of treating arthritis. People like to ask about what their alternatives to joint replacement are. I think it's important, again, to just go back to that idea that you can live your entire life with an arthritic knee or an arthritic hip. It's just a question as to whether you can tolerate the symptoms that come with that. And most of the people that show up and end up going to surgery are just people that they really have reached that place on their own.
More days than not. I usually tell my patients, you're going to come back and see me, and we're going to discuss surgery when the pain is unbearable and you're having it more days than not. At that point, usually for me, I'm an active member of our treatment team, so he'll initially assess the patient, or I will myself. I'll usually do the conservative methods of treatment, and then send the patient to you when it's time to discuss surgery. So,
and once that decision's made, I think whether there's parts of hip and parts of knee replacement that are similar, and I think we'll talk about those together, and then maybe as we get to the end, if we have time, we can sort of split up some of the differences in the two situations. We ourselves don't do a lot of shoulder replacement, but we have people at Cooper that do a whole lot of that work, and can certainly, if people have questions about the shoulder, make sure that we get you plugged into the right people. But when it comes to hip and knee replacement, again, failure of conservative treatment and really significant restrictions to quality of life. So our scheduling process is and has been in evolution, but we're in a pretty good place now where once we decide to do surgery, we have you interviewed by our nurse navigator who really helps with all the different procedures that are necessary prior to going to surgery. So that really includes medical clearances and the testing that's necessary for that. There's also, insurance pre-authorization and things that come with that. It's gotten a little bit more complicated as the years go by, but at the same time, we've got a pretty good system in place that really helps get people through this well.
I think what's unique about our program is that we are taking everybody as an individual. So we're taking all of your past medical history, your medications that you're taking, and we are taking all that into account when we're planning your surgical plan and post-operative plan, making sure you have the right clearances. Basically, I've been taking that task since I've been here at Cooper, and I think it's a great program, and we take into account everything when deciding what to do for surgery.
When you work at a place like Cooper doing what we're doing, Cooper takes care of sick patients in general in all fields, and it's no different in our joint replacement program.
Yeah.
And we do wind up being a destination for people with challenging medical conditions as well as arthritis. We take care of the toughest cases, and I think the strength of our program, there's a lot of skill at the surgical level with all the physicians that are involved in the program. But I do think that our biggest asset is our individual attention, and we really do try to not have people feel like a number and get like they're getting run through a mill. We are very, very, very careful with our risk stratification and making certain that that people are getting the individualized care that Nicole's talking about. We spend a lot of time trying to do that and make sure that even the toughest patients have the same kind of very positive outcomes that you would have anywhere else. But I think, going back to the idea of the plan, of the scheduling and the plan. So we have a nurse navigator who really helps get people with some complex history through the process to get them safely to surgery, and then typically once that's happening, a week or two before the surgery, we have the patients come back into the office, and one of the critical things that Nicole does for our program is really sitting with the patients for an extensive visit, making sure in the end that all the T's are crossed and the I's are dotted. I think it's been a really, really good thing for our program. Why don't you talk a little
it
bit
helps
about that?
expectations. So it's an education more than anything. So I'll bring the patient in we'll review again their past medical history, things like that, clearances, but also what to expect with surgery, what to expect when you're going home. I tell all of our patients that 50% of what your outcome of how well you do after a knee or hip replacement is us, and 50% is them. So I need the patients for us to be on the same page as far as physical therapy, as far as what to expect pain-wise. I say if I do my job correctly and manage their pain, and they do the physical therapy and the work they need to do afterwards, then it's going to be a successful replacement and surgery. So
I think that's really true, and it's particularly true. We're going to talk a little bit about the differences between hip and knee replacement, but I think knees are tougher than hips, and I think that the recovery is harder, and we do a lot of educating about that ahead of time, because the therapy, particularly after a knee replacement, is critical to the success of getting that done and having a good long-term outcome. So once we get someone to surgery, we're doing everything that we can these days to get people in and out of the hospital as quickly as possible. We are getting most people out the door on the first day and some on the second day. We're doing everything in our power to send as many people home as we can with home care and physical therapy. I think in 2018, the number of people going to rehab, an inpatient rehab of any kind, skilled nursing facility or otherwise, it gets smaller and smaller every single day. And I think it's important to understand that the hospital stay and the reason to go to rehab, it's completely and totally driven by logistical factors. I remember when I was training, we've been together, working together for 10 years. In the time that we've been together, things have changed dramatically. But if I even go back to my residency in the mid 90s or early 90s, I can remember people with these surgeries staying in the hospital for 2 weeks, and I'd be walking around the unit with a clipboard, sort of documenting how many more feet somebody walked today than yesterday, and it was a major ordeal. And now it's just not that way, and your rehab really isn't occurring in the hospital at all. The hospital is, if anything, a safety check. You've got to be able to demonstrate that you can safely, be on your feet, do a few stairs, and get home so that you won't fall down and have bad things happen.
And then we're sending therapists, nurses, aftercare to the house, usually
Absolutely.
for a week or two, and then outpatient therapy from there if necessary. So knee and hips a little bit different, so we can touch on that too. So
there are differences from program to program, and one of our differences, and I'll say it flat out, is that we are believers in physical therapy, where some others have sort of gone by the wayside there. I think that an organized program really helps put people in the right frame of mind to do the right thing, and we live in an electronic age where a lot of things can be done on an iPad or on a computer, and you can watch a video of somebody doing therapy after a knee replacement and say, okay, do this. I don't have a problem with that, but I think what it ultimately does is put the burden entirely on the patient, and for some of our patients, it's just not possible for them to be able to do that for themselves the way that they need to. So we're pretty big proponents of organized,
Formal, yeah.
in-person physical therapy. I mean, it may only be a couple of days a week because it's still a lot of the things that you're going to do on your own in between the visits that are going to make all the difference in the world. But we are very, very big proponents of that.
Get better quicker. Yeah.
Get better faster. It just is. I mean, it is true that to a large extent you will get better with or without, but you're going to get better faster and more direct if you have an organized program that you're following. We really believe that.
Should we touch on the recovery and the length and rehabilitation?
So again, in the hospital for a day or two and then heading home. And I mean, over the course, I mean, how long does it take people to get better? I mean, honestly, that's a tough question. I mean, it's a little bit different for everybody.
Yeah.
I mean, I break it down into two limbs, and what I tell patients, and when I'm in the room, I mean, we're not really in the room together, so we say the same things, but who knows exactly whether we say the same things. I think you're going to get better. I think you're going to get 90 to 95% better in the first 6 weeks. That last 5 or 10%, though, for some people it's another week, for some people it's 6 months, and in large part that depends on two factors. I think it's preoperative conditioning and weight reduction. Those, I mean, the better shape that you're in when you show up for your operation, the faster you're going to recover, and I think we see that fairly consistently. People ask me about preoperative physical therapy. Does it make sense? Is it a good idea? I think preoperative exercises. In 2018, where physical therapy is rationed by insurance plans, and you're not allowed to go too many times in the course of a calendar year, I still believe that the organized therapy, the bang for the buck, is best after the surgery. But I am a big proponent of exercise and activity prior to surgery to just make sure that your conditioning is optimized, because I do believe that makes a huge difference.
And it will enhance recovery afterwards.
Without a doubt.
Yeah.
So typically after any of these surgeries, they're going to come back to see you at 2 weeks. So they get discharged from the hospital, they go home, they do the therapy, they're going to come back to see you in a couple of weeks.
Yep.
And what kinds of things are you talking about?
So things I'm looking for at that 2-week visit. So obviously I'm examining their incision, so healing is a big deal there. Pain management. And usually at 2 weeks is when I'm starting to promote outpatient physical therapy from there. Starting to get people off of a walker or a cane or nothing at all, depending on the person. I'd say the second thing that I would, besides pre-op conditioning, is patient motivation, pain tolerance. Those type of things really play a factor in recovering. So I find my best patients with the best outcome are the ones that have great expectations or realistic expectations before surgery and are motivated to get better. I need to get back on my feet. I need to get to work. I need to go golfing again. Things like that. So
I think that's really true, and we both talk about and even joke about the fact that the longer you do this job, the more you realize that we're 90% psychiatrists most of the time. We have to do our job correctly, but it's really about understanding the psychology of the patients and the people and who they are. And some people need a hug, and some people need a kick in the butt. And it just depends on what it takes to get them going. But if you don't understand those factors of the people, and you don't have time to make it happen, which is another thing I think we really do our best to take the time. Again, going back to sort of personal attention and trying not to make people feel like a number driven through the system. If you've come to the office with us, we're not always on time, I can tell you that, but it's only because we're doing our best to try to make sure that people's questions are getting answered and they're getting the information that they need. And some days we do better than others, but we're always trying to do the right thing. So after they see you at 2 weeks, they come back to see me at 6 weeks, and that visit is sort of whatever restrictions have been in place, and frankly, every year there seems to be fewer and fewer restrictions out of the hospital, but by the time we get to the end, by the time we get to 6 weeks, just about any restriction that you had is gone by the wayside, and you can pretty much do what you need to do. People oftentimes ask about driving. It used to be a 6 week answer. Pretty much now it's based on the simple answer that you've got to have control of your right leg to be able to get on the brake if a little kid runs in front of your car. So if you're off of medication and you are doing well with your physical therapy, you know, for a lot of people, that's only a couple of weeks away, and that's true for work as well. I mean, depending on your job description, it could be as early as 2 or 3 weeks back to work. It could be 3 months. It depends really on the person and what the situations are. What else? Any other thoughts about a 6-week visit? I mean, we're continuing physical therapy if people need it at that point, but by that point, people are pretty happy. They're pretty much where they need to be. I think hips are generally happier than knees across the board, just because therapy is a little bit easier for the hip patients. But in general, people see the light at the end of the tunnel and are making some progress.
Yep.
And then they come back to see you at about 3 months.
Yep. Now, 3 months, that visit is usually for me wrapping up physical therapy. Not everyone stays in that long. And then any work restrictions.
Getting people back to work that haven't gotten back. And then kind of catch and release at that point. Go live your life, and we'll see you for a 1-year anniversary and go from there. I also should mention that I check an x-ray at 6 weeks. It's really not looking for trouble as much as it's chapter 1 in the storybook. It's the first real full set of x-rays. We get some x-rays in the hospital, but it's really just to document that there hasn't been any real trouble. So, and then we do things again at a year for a 1-year anniversary. But really, by the time we get to 3 months, I mean, things are pretty well in hand, and frankly have probably been well in hand for several weeks prior to that, but really making progress.
Do you want to answer Kathy?
Yeah, Kathy on Facebook had a question. He said, I had a knee replacement a year ago, and I was told I need a new replacement because of loose pieces or parts. Can you do a knee replacement or revision? And the answer is sure. It's unfortunate that you had your surgery a year ago and now you're having trouble with it. You know, I think there's a couple things that I say. One is that surgery, we live in a world where every day surgery becomes, at least to the world view, simpler and easier. And the results are better and the expectations are higher. I think one of the mistakes that we occasionally make is that we can't lose sight of the fact that it's a big operation. I mean, we're still doing things to your body, and while we get better at it every day, that doesn't mean that no one gets an infection. That doesn't mean that nobody gets a blood clot or other complications that can occur, and parts can get loose. I mean, these things can happen. So it's one of the reasons, again, why we are so adamant about doing non-surgical things first and really viewing the surgery as we have to do this because we have no other choice. Because even when we do our best, it's a 99% world. It's not a 100% world, and things like what happened to Kathy can happen. So the simplest answer is yes, we can make those things better too, and we can do second-time surgeries. And if things get loose or if parts wear out, there's certain things that we have to do to make sure we understand why it happened and prevent it from happening again. But the answer is don't feel that you have no options or any recourse. The problem is that very few of these things can be solved without more surgery, and that's not necessarily what Kathy or anybody else in her situation wants to hear, but it is the reality. The good news is we can fix it. The bad news is that you're going to need another surgery to do it, and you probably didn't have that much fun getting your first surgery done. But certainly it's something that we can deal with. You know, I think in general, you know, the success rates, and I gauge success by, we in orthopedics gauge success by patient satisfaction, really. I want people to be happy. You know, if I look at an x-ray and say, hey, the x-ray looks great, but the patient's unhappy, that's not success. And I think that again, the national hip success rates are north of 95%, 97, 98%. It's a very, very good operation, and the therapy is, like I've said a couple of times, a little bit easier. I think knee replacement is probably somewhere between 92 and 95, depending on who you read. It is a little tougher. When knees get stiff, it's a challenge. I mean, we see that. Half of the reason why we do these visits and we stay on top of people, particularly the knee patients, is trying to drive them to do the work.
Yeah, encouragement.
Yeah, I mean, we've seen it happen when people, if we sat in a room, and I say it, if you've been a patient with me discussing knee replacement, you've heard me say this. If we sat in a room with 100 people that hate their knee replacement and said, what do you think happened? It's almost always the same stories. It's a lot of people with stiff knees, either because they get scared of the pain or because they their therapist wasn't as aggressive with them as they needed to be, or they weren't serious about the therapy and the situation afterward. I mean, we've seen it.
Yeah.
And it's a very, very in knees tough thing to fix after 3 months. So we do everything in our power to create a scenario where we're watching and that we're supporting people to do what they need to do.
Yeah, and I say a positive outcome. Usually I tell my patients is when you forget you've had it replaced. So you're, going back to work, you're walking without a limp, up and down the stairs, doing laundry at home, and not taking that step and feeling pain. So, I usually say 3 to 6 months, I would expect you to forget you even had it done, if not prior to that, depending on the patient. So, yeah.
It's different for everybody, and I think look, we all have 2 eyes, a nose, and a mouth. Nobody looks the same, but that's absolutely true of these surgeries. That's absolutely true of the recoveries after these surgeries. Nobody's the same. Even if you have 2 knees done, your one knee probably won't feel exactly the same as your other one did, just because they're independent events. But I think by and large, these are successful things. People are happy after they're done. I think that we really do a pretty comprehensive job of trying to get people from the beginning to the end in the best possible way that they can, and we promise to. You can't promise much in this world anymore, but we promise to always do our best and try to treat you as an individual and understand your specific needs. I think that really is the strength of what we do, is we really try to take the time in a world where it's hard to do that. We're going to make sure. I think we're getting close to wrapping up here, and I think we're going to make sure that if there's unanswered questions, or if you'd like to make an appointment or like to contact us, that all that information is readily available to you through the site here. But again, we really hope that you found this useful. Nick, you have any last words or anything you want to add?
No. If you have any questions or concerns, yeah, exactly. Address or ask them, and we will address them gladly. Yeah.
So we promise to do our best for you. So thank you for the time, and I hope you have a great weekend.